Mhm.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good evening, everyone, and welcome to our CATHIP Health Hour, midweek edition. Hope you've had a good day. This evening, we are privileged to have Dr. Mohammed Kamara, who is a consultant in emergency medicine and no stranger to our CATHIP sessions. I'm going to hand you over to Dr. Kamara, who is going to speak to us about a really live topic, monkeypox. So over to you, Doc.
Yes, yeah. Hello, everyone. Thank you for having me. I think we all do understand why people might be a bit touchy, a bit concerned in view of what we have been through in the past 2.5 years and counting. So for us to probably have gone through such a big ask of, combating COVID-19. And just as we think we're turning the corner, something else rears its ugly head. Another one of the viruses, is now challenging, patients' resilience. And so it's obviously important to talk about it, because when it started, it was one thing to say, yeah, we know about that. It's been, since 1950 something, but just one case would not be of any significance. All of a sudden, you're looking at it spreading to over 30 countries in the world, and we're heading towards 2,000 in a very short period of time. That said, there's also the issue of it being stigmatized, i.e. the people who actually fall victim of this dangerous virus, are stigmatized, and most of the ones who've been found to be afflicted by this are the ones, they say, of reduced or lowered immunity, so immunocompromised, or men sleeping with men. So one has to be really careful when you're categorizing that. And as a result, today, as we speak, the World Health Organization has actually decided to meet to decide on two things. One, to try and see whether they can rename this illness from monkeypox to something else because of the stigma attached to it. And secondly, to see whether the level could be raised from moderate to probably of high importance internationally or globally, if you like. So it just goes to show you that this is something that is serious, and therefore WHO is, at it, trying to get things moving forward to the point where hopefully we can get on top of it. But it's a far cry from the COVID that we've actually just managed to control, or maybe, so to speak, put a lead on. But as we speak, there's 40% increase of COVID in just 1 week. So it's still there. It's still, rearing its ugly head and still wreaking havoc. But obviously, because of the vaccine, thankfully and mercifully, things are not as they were a year back or a year or two back. So this is just a preamble that we need to be aware of this, and we need to make sure we're making strides in trying to combat it. So I'll go forward and I'll tell you a bit more about it. So next slide, please. So here we are. The first case, as you would have heard, like up to almost 2,000 of it. In the UK alone, there's about over 700 cases already. And the very first case was a case that was, if you like, discovered or diagnosed where else? In London, at St. Thomas's Hospital. And this person who was first diagnosed in the UK had actually recently visited Nigeria. And I'm not quite sure whether they're Nigerian by birth or by origin, or maybe just, if you like, a tourist or something like that. But definitely that's the very index case, if you like. But then thereafter, as you can see, it's mushroomed, in most of the countries. As I said, over 30 countries in the world do have that. And you'll probably confirm when you watch the video that I'm going to show you later on. Next slide, please. So, like everything else, it's always important to look at the epidemiology, i.e., what we know about this virus. Now, obviously, we would have heard, and we know now, that the coronavirus is an RNA virus. And it makes mistakes, it's when it goes into the body of a human being, it replicates, it multiplies. And so when that happens, the way with the RNA virus, it makes a lot of mistakes. That's the simplest way I can explain it to you. And therefore, it drops a few hints along the line, and that's why it changes like nothing else. That's why you've got the alpha, beta, gamma, and delta. And the other ones, the Omicron and delta, that have actually come to be known subsequently. Whereas with a DNA virus, which this monkeypox is, it is a very sturdy, very steady one, strong, that doesn't make mistakes when it replicates, and therefore it's easier to tackle compared to the RNA virus. And that's why you would notice that most of the RNA viruses do not have vaccines, whereas the DNA viruses do have vaccines. So it's called monkeypox, obviously, because it was first discovered in monkeys. Next slide, please. Yeah, so you can see, as I said already, it's a DNA virus. It comes from the family of Poxoviridae. Now, you might think, what is Poxoviridae? Now, pox, the original word is poc, P-O-C-C, which is a pus-filled blister. I repeat, pus-filled blister, which over the years became known as pox. And as I said, the reservoir, we're hoping that is the right one, is monkey, squirrels, rodents like the rats, and of course, those who did biology, agriculture biology, would tell you this is a zoonotic illness. It obviously comes from animal as well. There's no vector that we know per se. It may well reveal itself later on. As we know, what we've heard so far, the vehicle of spread is obviously by contact, by respiratory airdrops, and by pharyngeal aspiration of it, yeah. And then, of course, incubation period, that is the time when you get exposed to the virus to the time of your first symptoms, can range between 5 and 21 days, and on average, as you can see, 5 to 21 days. It's like between 1 to 3 weeks, you can get that, you know. The tests, obviously, you might not need to know about, but when you get to the hospital, these are the tests they will do, and they would actually reveal whether, yes, indeed, serology has actually confirmed that, yes, this patient has got this or hasn't got that, you know, because the monkeypox is very similar to other viruses. Now, you'll find out, as I said, it belongs to the family of poxviridae, which include a lot like smallpox, chickenpox. There is cowpox. There is one thing they called molluscum contagiosum. It can even look like syphilis, can look like chickenpox, can look like some form of cancer as well. So there's a lot of you know, rashes that look like this. But one thing that distinguishes the monkeypox from the other smallpox that you can think about is that there is this swelling of the lymph nodes in the neck, in the armpits, in the groin, either one side or both sides. That's one thing that distinguishes them. But the backache, the exhaustion, the shortness of breath, you know, and all of that is common to the rest of it, the other viruses. So that's one thing you need to know, you know. And of course, there's no specific treatment apart from the smallpox virus, which we know is 85% effective. You know, the efficacy of that is high compared to the other treatments they want to sort of look at, antivirals they're thinking about. You see them as we go along, but mainly it's the smallpox virus, which we know is quite effective. And of course, to support that, you have the supportive, you know, therapy. Like if there is a blister which is infective, then obviously you might need to have antibiotics with it. If there's pain and, you know, temperature, you might need some anti-inflammatories, you know, antipyretics, you know, as they call them, the painkillers and the anti-inflammatories. So that's the way it is. And of course, you need your PPEs. You need to make sure you avoid, you know, that contact. But I must tell you that for you to get that airway infection, there has to be a prolonged period of your presence with somebody who is infected. And that's why you'd see where, as we go along, you'll look at the mechanisms of prevention at home and at the hospital, what needs doing, really, yeah. So the treatment for children is no different from the treatment for adults. You know, it's just that, you know, you find it difficult to put the masks on in a child as opposed to an adult, really. All right, next down. So this is just a distribution, a map of distribution, you know, distribution of the monkeypox in the world, as you can see. Now, red is a country where it hasn't been available. Now, this data might not be as recent as it is now, because even Sierra Leone, which had not once reported a case of monkeypox, does have one now. You get to find out from the video when you listen to it. The white ones in, you know, the white parts of the world, this is where it's non-endemic, i.e., it is not known to be consistently, you know, known or, you know, sort of discovered. And then, of course, you got the light green, which is sporadic, yeah? And then you have the endemic. And the endemic one is as you would have noticed, the endemic one is, sorry, I've just been distracted here. Yeah, the endemic one, as you can see, some people, when I presented this topic last weekend from afar, one question that came up was, why is it that Ebola stemmed from Central African Republic, you know, Congo and all that? And of course, now we're looking at, you know, monkeypox, which, as you can see, is endemic. Now, I couldn't answer that, whether there's something in the terrain, whether there's something in the soil, whether there's something in just the way nature has, you know, sort of dished them a curved ball or not, I'm not sure. But that's the question they asked me, and it was a very good question. So I thought I probably need to research that and maybe pose that to Professor Payot, who discovered Ebola, and maybe he might be able to help. But that's just something to give you an idea as to what is happening. Next slide, please. So here you go. I'm going to say most of this I've said already. So the history is that the monkeypox was first discovered, as I said, in the 50s, 1958, when 2 outbreaks of a pox-like disease occurred in colonies of monkeys that were kept in research. They were being researched upon, and so the name monkeypox really. Since then, monkeypox has been reported in humans in other Central and West African countries, as I say. Now, Liberia and Sierra Leone are now included in this figure. First case, 0 case, as I say currently, I said already, was from someone who either was visiting Nigeria or maybe has emigrated from Nigeria. I'm not quite sure, but that's how it is really. Yeah. Next slide, please. So, as we say already, it's monkeypox. What is it? It's a rare illness, obviously, a rare disease that is caused by, monkeypox virus, which belongs to this orthopox virus, a genus of the family of Poxiviridae, which includes, as you can see, variola, which causes smallpox, vaccinia virus, which causes smallpox, and of course, cowpox. I mentioned that already. And there's another one they called, molluscum contagiosum, which is one they contract when you go into the pools. It looks like a raised pearly, looks like a pearl, but with the umbilicus in the middle of it. It's like a punctum in the middle of it. It's obviously infectious because you contract it in the swimming pools, but sometimes it's one that actually is self-limiting. It sort of limits itself, and that's it really. You might not need any treatment for it, just disappears on its own. The natural reservoir of monkeypox remains unknown. I want it to be clear. However, African rodents and non-human primates, like monkeys, may harbor the virus and infect people. Next slide, please. So what are the signs? So when someone contracts it, what are the signs? Well, in humans, the symptoms of monkeypox, obviously, when you compare them to smallpox, they're milder. I think you'll see later on as we go along, the difference between pictorially and distributively, how they are in terms of anatomical sites of the body. One of them is more so on the face than the other. The other one is more on the arms and the legs than the other. As I say, but there's a commonality amongst them. So there's fever, there's headache, there's muscle ache, there's pain, and of course there's exhaustion. And if it involves the chest, of course, shortness of breath, difficulties breathing, and coughing. Incubation period, as we said already, ranges between 1 to 3 weeks. On average, normally, usually it's 1 to 2 weeks, but can range between 1 to 3 weeks, as it were. We mentioned that already, that the distinctive difference between the smallpox and the monkeypox, which is very, very similar, is the lymph nodes that swell in the case of the monkeypox as opposed to the smallpox. Next slide, please. So this is just a confirmation of it. Now, the lymph nodes may swell, and they would be in the neck, either the ones that you use when you're chewing, the ones that help to give you saliva. That's the mandibular lymph nodes and the glands and all that. They swell, and the ones in the neck, they become painful. Of course, in the armpit, they also swell, both sides, right or left, or both sides, or the groin can be either one or both sides. So this is just confirmation of what I've just told you already. Next slide, please. So this is just a graphic, representation of what I've just said. And you can see the difference, as I say, smallpox on the right and monkeypox on the left. And as I say, it's there, the fever, the headache, the backache, the blisters, the rash, and of course, fatigue, exhaustion. But then on the left, there is definitely the swelling of the glands, which you can see. So it's just confirmation, and it's just representative of what I've just told you already. Next slide, please. Right, again, this is just dermal manifestation. It shows you how it looks like. On the dark skin, i.e., our skin, the people of color, and of course the Caucasian skin, it's a good thing to be able to compare. One thing we lack in this country, or maybe in other parts of the world, is that most of the textbooks, especially in dermatology, they actually cater for the Caucasians as opposed to the person of color. And that sometimes creates a bit of a problem. That's why some diagnoses are missed, and then it becomes a bit difficult when it would have been too far gone. But it's always important to remember that, it's different in the way it manifests itself in the darker skin compared to the lighter skin. All right, and you can see the distribution, it varies. There's more so in the limbs than in the torso, i.e. the chest and the abdomen, which is completely the opposite. When you look at chickenpox, you would see what I'm talking about. The picture would actually reveal what I'm talking about. Next slide, please. So there you go. Like I said, if you look at, chickenpox and look at the distribution of smallpox, you could see that obviously the face on the left is definitely more densely affected or, infected compared to the right. You look at the chest, it's less so on the left compared to the right. And if you look at the limbs, the lower limbs and the upper limbs, you can see it's absolutely covered, in smallpox compared to chickenpox. So when you've got that picture on the left, imagine that with the swelling in the armpit, the swelling in the neck, the swelling in the groins, then you now get a full picture of what we're talking about in monkeypox. All right, next slide, please. So yeah, as you can see, when we talked about this, the rash, you could see that within 1 to 3 days, the patient, develops this fever, and then that is followed by this rash. Now the rash can range from these stages: macules, which is a flat red rash. So it's flat, it's not raised. The papules, they're red, but they're raised. Yeah. And then the vesicles means they're blisters. And these blisters have got clear fluid in them. That's why it's called vesicles. When it becomes filled with pus or colored like cloudy fluid, then it becomes what we know as pustules. Now, pustule is a pus-filled blister, and that is where the name came from, POC, that POCC, and later on became named as pox, which means a blister that is filled with pus. That's why it's called a pustule. These pustules will crust, they will scab, and then once they scab, they will then heal, leaving sometimes very deep scars, on the face or on the trunk or on the limbs or any of the area affected. The illness typically lasts between 2 to 4 weeks. When it's resolved, as I said, these scars may be pitted, and that's why you get the pock marks. If you look at the likes of Ramses V, Pharaoh, when they looked at his mummified torso, they found pock marks on him. And even the Mexican leader in the 16th, 17th century, they found pock marks on their faces. So they must have definitely had some form of that. Once the one thing you must know is that that person who has got these scabs would probably still be contagious, but once the scabs are fallen off, the person is no longer contagious. In Africa, that's the last thing, on this slide, monkeypox has been shown to cause death in as many as 1 in 10 persons who contract the disease. Now, the general mortality rate is between 3 and 6%, but definitely it's been found that the ones from Central Africa are more so in terms of fatality compared to the ones in West Africa. Next slide, please. So here you go. This is just a pictorial evidence of what we just said. You could see it, what happens 24 hours, if you look at it, it's like, macules and papules. And then, of course, it becomes, a pustule. And then the pustule will then scab. And then, of course, the scab will then heal and the crust will all fall off. And at that point in time, that patient would be, symptom-free and, of course, would not be infective anymore. But you can see that obviously the blisters can be tense and can be painful and can be really, really infective to the point where these people will get like a temperature and things, feel unwell and restored. So they may well need antibiotics, strong intravenous antibiotics as well. Next slide, please. So So again, these are just the risk factors which we know are common, and we know what they are in terms of the severity of the illness. This can depend on the initial, what we call pre-morbid state of the affected individual. The West African monkeypox is, as I said already, is associated with milder disease. The tendency, the trend is milder, and the deaths are fewer ultimately. Limited to human transmission, whereas on the other hand, the ones the other side of Africa there are a lot more infective, and obviously they're severe in comparison, and they have a high mortality. And of course the person-to-person spread is well documented for Central African monkey virus. Next slide, please. Yeah, so the transmission, as you can see, contact with the virus from an animal, or a human, or materials that are contaminated with the virus via the broken skin, which may be intact in your eye. So your eyes don't think this is broken, but then it is there. And even if it's just a micro breach, the virus can actually gain entry into the body and can cause problems, as it were. And of course, the respiratory tract as well, because if someone's there talking to you, or someone who's caring for this patient, and the crust has actually fallen on the linen, and the linen is being, tidied, and they had to shake it, and that powder form of the crust can actually be inhaled, and that can cause the respiratory aspect of it, and that can cause problems with that. Apart from that, it can go through the mucous membranes, like the eyes, the nose, and the mouth. As I say, human to human is possible. Is more so with the Central African Republic one in comparison to the West African one. But for that, you definitely need a long exposure. You need at least 20, 30 minutes or something like that for you to be able to say, this has been successful. Other than that, it's mainly from the bites, or from a scratch, or from eating the infected meat, which is something we know or of a delicacy in the parts of the world that we hail from. Next slide, please. Right. So, as we said already, it's the virus that causes this monkeypox has only been recovered or isolated twice from an animal in nature. The first time that happened was in 1985. The virus was recovered from an apparently ill African rodent. It's a rope squirrel in the equatorial region of the Democratic Republic of Congo. And in the second incidence, it was in 2012, which is like 10 years ago, when it was recovered from a dead infant manga bay. I don't know if people know what that species of monkey is. There's a kind of monkey which is called manga bay, which was found in the Thai National Park in Ivory Coast. So these were the two times when that was, or twice that this was, sort of recovered from, the African, West African side of things, really, yeah. So we're not quite sure how this has happened, whether there's migration, whether there's just a breach, whether there's just a freak or not, we don't know. But as we say, it's not endemic in our regions. However, it has happened, and it's now been imported into the UK, and that's where things stand. And of course, in other countries, like 39 countries in the world, this is now becoming a cause for concern internationally and globally. Next slide, please. So this is just, again, a graphic representation of what I've just said, how it spreads primarily, and of course, human to human transmission, primarily, again, as I said, from bites, from scratches, from consumption of the bushmeat, which, as I say, I obviously urge people not to indulge in, but as I say, people have traditional values, cultural values, and things like that, but there you go. It's been known to be the source, one of the sources of actually contracting it. So maybe avoiding it might be a good thing to do. And of course, the human to human transmission, through close contact with an infected person, and of course secretions or the skin lesions. That's what has been documented. Next slide, please. Yeah, again, prevention is, as I said, there's nothing new there. It's just avoid, isolate when infected, and of course practice, safety, your PPEs and things, and you use, as I said, your PPEs when caring for these patients. And of course, you need to isolate. As you know, the incubation period between the time you get exposed to the time you get infected is like 1 to 3 weeks. So obviously for that time when you get diagnosed after the blood tests, you probably might need to isolate like you did with COVID-19, only maybe a bit longer than it was really, yeah. So avoid contact with any of, the materials such as the bedding, and of course a sick animal, and of course, as I said, practice, the good hand hygiene, wash your hands properly. There's nothing better than washing your hands properly. And of course, making sure you are protecting yourselves, your visors, your masks, your PPE. And that's what we always advise. With that, you can minimize. And of course, if you're disposing any of the linen or the material that has been used, like dressings, the linen and all that, you have to do so according to the guidelines nationally and of course locally, and of course according to the local trust. Next slide, please. Again, it just tells you, what to do. Not everybody will need or require hospitalization, just like in the case of COVID. If it's mild, then obviously there is, to all intents and purposes, likelihood that you will be able to recover at home, because there's nothing apart from giving you the supportive treatment with the smallpox, if you like, a vaccine. Then obviously there's not much more you can do apart from just protect the patient and protect yourself, and that's it. Obviously, it's a bit difficult when you're looking at a child. You're looking at isolating them. That poses a lot more challenges than when you're looking at an adult. You have to be taking these individually by merit, depending on the nature and the extent of the lesions in each and every case. Next slide here, please. So again, infection at home, we've just talked about this already. Household members who are not ill should limit contact with the person with monkeypox, definitely. Pets should be excluded from the ill patient's environment. Unexposed persons, who will not have, who do not have an essential need to be in the home should not visit. So these are all basic standard stuff, really. Yeah, if you don't have to be there, you don't need to be there. Of course, you need to isolate the patient, but it's important to remember that we need to be protective of ourselves, of our animals, of our family, of our children. And that way we can actually stop this, because it's not the same as the COVID-19 where, it spreads like wildfire. This is not the case. And to top that, we've luckily have got a vaccine that we know is 85% effective. Next slide, please. So this is at home. Again, it's just continuing, disposing of the waste according to what we need to be doing. Skin lesions should be covered, using long sleeve shirts, like pajamas, long trousers and things, and just cover them so it doesn't, get infected in terms of the linen that they're sleeping on and all that. And when you actually getting rid of those, it has to be done in the proper way and not in a haphazard manner, because somebody else might just get infected, really. So it's more like personal hygiene and safety measures that we take with any other illness. Next slide, please. So the decisions, one has to take regarding the discontinuation of the precaution should be made in consultation with the local or state health department. Now, obviously, as I say, this is now becoming a notifiable illness, so if anybody's got it and it's been diagnosed with that, there is a number you can call to notify, especially from the hospital. or from the centers, like the infectious diseases center, one thing you have to know is that the isolation has to continue until all the lesions have resolved and a fresh layer of skin is formed. Following that, precautions, patients should avoid close contact with immunocompromised persons until all crosses are gone. Again, similar to the COVID-19, if you got COVID-19, even though after day 5 or day 6 you might test negative, you're advised to avoid getting close contact or close to someone who is immunocompromised. Same applies here, because although you are recovering, but that person's immune system might be so weak that just one simple exposure might just end up causing them a lot of aggro. So it's important to maintain these standards, really. Next slide, please. Yeah, so in the hospital, I mean, you obviously, when you get to hospital, you'll get to see this. This is mainly for us, the way we send these soiled laundry, soiled linen and other waste, medical waste and all that. How we handle them is something we need to be aware of, the equipments that we use, we need to clean, and we need to reprocess them, like the autoclave and all that, appropriately. Hand hygiene, I cannot stress that enough. It's definitely important, especially when you come in contact with the patient. And that is why we always advise to wash our hands before dealing with the patient, gloving up, and then after that, degloving and degowning. And then, of course, making sure that the hands are washed after that. And then, of course, the hand sanitizers. So there's a lot of things that have been said about the way we do things, but there's no difference, in what it is. And of course, the laundry, the towels, and other things, all of these have to be disposed of or washed in a proper way, in the appropriate way. Otherwise, it would just be a circle that will be repeating itself. Next slide, please. So these are just, as I said, it gives you an idea as to what they're trying to do. The FDA in America, who are the leaders in this, for the prevention of monkeypox, have suggested this, but there's no confirmation, there's no proof to say that they are as effective as the smallpox vaccine, which, as I told you already, is 85% effective. Next slide, please. Charles, next one, please. Yeah, so again, that's it. So none of them has been proved to be effective in comparison to the smallpox one. The purposes of controlling a monkeypox outbreaks in the US in particular is the smallpox vaccine, the antivirals, the vaccinia, immunoglobulin. They can use all of those, but as I say, nothing beats the smallpox, which is, as I say, stands at 85%. That is why in the UK, they've stocked up to 20,000 vials. In fact, the most recent update today is that they're actually putting together a list or a database of all these men who they think are prone, the ones who are bisexual, the ones who are, gay and all that. So it's like in the case of HIV, there is what we call post-exposure prophylaxis. So it's PEP. And then they have pre-exposure prophylaxis, which is PrEP. So they're actually applying that same principle here with this one. So those who they know are vulnerable, who are in that susceptible category, are the ones that they want to aim at recommending this vaccine to, so that at least they'll prevent a further outbreak or further worsening of the situation, as it were. Because, as I said, WHO has found out that this monkeypox is now posing a global challenge, is becoming one at the highest level. And that is what is happening today. So therefore, they're acting and wanting to do something to stop it in its tracks as best as possible. Next one, please. Yeah, again, this is just, to tell you about, the vaccines, and is that they don't, because you have like a live virus, a live vaccine, and the live vaccine we know has got some dangerous and very, very strong side effects. And so therefore, it is not licensed for use for the under 18s, the only ones who can use it. similar to the yellow fever vaccine, it's only for adults, i.e. 18 years and above. Nobody else under that could get that offered to them, you know. But that's how it is, you know, because it's a live vaccine, as opposed to the watered down or altered, vaccine like the other ones we know already. Next slide, please. So yeah, again, this is like the antivirals, you know, which, you know, cidofovir and brincidofovir, they're all in like experimental changes and stages. There's nothing that is confirmatory as to the efficacy of them, really, as opposed to the smallpox vaccine, really. Yeah. Next slide, please. So again, it's just giving you, you know, the vaccinia immunoglobulin, which, you know, we don't know how effective it is compared to the smallpox vaccine, but they're there and you need to know about them. Yeah. Right. Next one, please. So these are my references, and not all of them, not by any means exhaustive, but this is just some of the ones that I thought were important. And the next slide is just to thank you all. These are just the languages that I think I can say a word or two in here. And perhaps Charles can manage to get the video on, and you can then see what we're talking about in terms of to aid comprehension as to the importance and the significance. I think you need to watch this.
I can confirm that there are now a total of 1,900 confirmed cases in 39 countries across the globe, including 8 African countries. Of those countries in Africa, monkeypox cases have been previously reported in 6. There have been 36 confirmed cases in Nigeria, 10 in the Democratic Republic of the Congo, 8 in the Central African Republic, 3 each in Benin and Cameroon, and 2 in the Republic of the Congo. Ghana and Morocco, which have not previously recorded cases of monkeypox, now have 5 and 1 confirmed cases, respectively. Additionally, Ethiopia, Guinea, Liberia, Mozambique, Sierra Leone, Sudan, and Uganda, all countries with no previous incidents, have also reported suspected cases. This is clearly an unusual situation that is affecting more and more countries. So soon after the inequities Africa experienced in respect to the COVID-19 response, we recognize, of course, that we cannot afford any potential repeat and need to be adequately prepared. So WHO is convening an emergency committee on monkeypox next Thursday, the 23rd of June, to assess whether this outbreak represents a public health emergency of international concern. However, as WHO in Africa, we're already ramping up support to countries to urgently increase testing capacity for monkeypox, and we're in the process of procuring thousands of tests for the continent. As far as the vaccine is concerned, one of the newer and safer smallpox vaccines has been approved for the prevention of monkeypox. Although we're certainly not recommending mass vaccination at this stage, we must ensure that we are ready should the need arise. Global stocks are extremely limited at this stage, but we're working closely with member states and partners on a coordination mechanism to ensure fair access to both vaccines and treatment.
Thank you so much.
Brilliant. Thanks a lot, Dr. Kamara, for such an insightful presentation. So I think we have about 30 minutes for some questions. And I think there's one in the chat box. So can monkeypox be categorized as a sexually transmitted infection as well? That's the first question for you, Doc.
Interesting question. Now, I can't say it has been categorically confirmed. I know that one patient from the almost 2,000, the virus has been found in the semen. So whether that categorizes it as an STD, I am not sure. I don't think that would be the case. It may be just one of those that's not being, confirmed, or maybe it still needs work on. But so far, that is not an established or, if you like, confirmed route of spread or transmission, Yeah. So that's the situation, as it were. There's only one patient in whose semen the virus has been found. I don't know if that answers the question.
Yeah. Thanks, Doc. I'm sure John will come back if he needs further clarification. Another question, what's, in your view, what are the underlying reasons for the higher prevalence among men having sex with men?
Well, I mean, as I say, immunocompromised, people who have got, who've been infected with the HIV virus, who are not aware of it. Remember, there's still the stigma, and as a result, people don't come forward. Even though there's anonymity, a lot of people are very conscious of the fact that it's still highly stigmatized. So therefore, when this happens, in 1980, when the HIV, virus was discovered, full well that there were people who were living in the closet, if you like. They lived like double lives, and so nobody knew this. But of course, you go get yourself exposed to the virus, you come and live with your family, and therein one thing leads to another. So it was like moving from an illness or a disease that was exclusively known for gays to even the heterosexuals, because of what has happened. You see what I mean? Because of the stigmatization. So if people do not know they have immunocompromise and they now get exposed to the virus, then obviously they stand a far, far higher chance of contracting it than somebody who's got a robust health system or immune system. Remember, you can get a virus, you can catch a virus, you can get a viral infection. It would actually be self-limiting if you have a very good system to combat it. It only becomes a problem when your immune system is compromised, when it's weak, and therefore it needs topping up. And without that, it becomes a problem. So that's why, it's been found, according to the statistics, it's been found to be prevalent in men sleeping with men, bisexuals, gays, and things and all that. But as I said, because of the stigma, hence the reason why WHO is looking at probably changing the name, and ensuring that, things don't get out of hand, really, because, this is like causing a bigger problem, i.e. people will then go inwards, if you like, instead of trying to come out and seeking help, because they know that they're being stigmatized, obviously they'll go in, and if they go in and they go on and spread it, well, then it becomes much of a bigger problem, really.
Yeah, thanks for that, Doc. There's another question, if there's any planned mass vaccination against monkeypox.
No, I think I answered that in my presentation. I don't think there's any forced, or if you like, or mandatory. They're actually setting up the database, as I say. They've got 20,000 vials, maybe more, but they have a database of people who obviously they know are, openly gay or bisexual and things, or people with immunocompromise and things like that. So they are the ones who this vaccine will be recommended to. I repeat, recommended to. Yeah, it's not going to be a mass vaccination. It's just like, it's not like COVID, where you stand there, I speak to you, I cough at you, I sneeze at you, and you are likely to catch it. No, you need an extreme exposure of that droplet for like 20-30 minutes at a time for you to be able to say you get that, and of course, if you don't get bitten or scratched by an animal and you don't eat the bush meat, then the likelihood is quite low. Plus, of course, if your immune system is quite good, you'll be able to fight it yourself, even if you got exposed to it. So the fact remains simple that, it's not something that would be compelling at all. No, definitely not. They don't even have the vials because remember, smallpox was like almost non-existent, you see what I mean? So for you to say, what's it called? The population of England on its own, 60 million, to be able to get that, I think is just unthinkable. It's just a no-brainer. So they're only focusing on the high-risk category. Simple as that.
Right. Thanks, Doc. Any further questions from anyone? And Doc, whilst others may want to unmute and ask their questions, So, the number of cases identified in the UK, do we know, how that's come about, or the source, and any more sort of breakdown of that data?
I don't think I have the exact, if you like, I think you're wanting to see the demographics, is it? I am not sure that is in public knowledge, if you like. As I said, we're living in a politically correct world, as it were, and so people are very careful with suits and things, legal suits, and so they get very careful. And besides that, there is the anonymity issue, whereby you find people will only trust you if at all they know. Obviously, the anonymity is maintained. Do you know what I mean? So if you are then exposing these people, what do you expect for them to do? So therefore, I don't think they'll be making this public knowledge. They'll tell you that so far we've got 770 something in the UK, from one patient in a few weeks ago, maybe a couple of months ago, to 7. So it tells you there's an exponential rise. It is rising. How it's rising, nobody knows. But I know the very first case was in London, and from there on, it spread. And as I say, I hasten to say this was a case that was imported. Do you know what I mean? So one thing they know, though, is that, one, it's become a notifiable disease. So anybody who diagnoses this in the hospital or anywhere else, maybe in the centers, would definitely need to inform the authorities. There's no questions about that. And anonymity has to be, maintained. That's 2. 3, from what they've looked at, I think they've gone on and done like a survey, and they found out that the vast majority of the people who have been afflicted with this are people of that category, that kind of lifestyle, orientation, sexual orientation. And that is all one can say. But to say African-American people, Afro-Caribbean people are 40% and this and that, I don't think anybody can tell you that, because that is just a recipe for disaster, in my view.
Great. Any further questions? So, Doc, as we wrap up, what are the symptoms, or what should people look out for, and sort of take home advice, really?
Well, the advice is there, and the symptoms are there in the presentation. You can see for yourself that obviously, if you have somebody who's a friend or a relation and things and all that, and obviously actually develops this kind of symptoms that we highlighted, the headache, the fatigue, the exhaustion, the pain, the backache, and of course the lymph node swelling after exposure to either an infected animal, maybe a pet, or maybe having gone to somewhere where it's endemic and the rest of it, or you are somebody of a certain sexual orientation and the rest of it, then obviously you need to get yourself checked out. That's all I can say to you. So there's no point in sitting at home and things like that. If you doubt it, we'll get yourself checked out. And if you get checked out and you're found to be, infected with it, then the sooner the treatment starts, the better it is for you. And that way, once you've got the diagnosis correct, you then are able to fight it. In fact, I can tell you, it's now got to a point where one of the cases that I remember is one where the typical rash did not appear on this chap. So it just goes to compound things. Do you know what I'm saying? And the only way they could confirm that this guy had this thing, this monkeypox, is by the blood test, the serum. So when they did the blood test, they found it, but typically he did not have the rash. But of course, this guy was, a gay, and so he was saying we have to be very careful, and that was his advice, lest we just unleash a beast, which would then obviously come back and haunt us, and we don't want that. So this is why one has to be very careful. But it's the usual routine. You've got a patient who has got an illness. Remember your hand hygiene. It's absolutely vital. Your masks. Your isolation period. These are all not anything new. These are things that we all know are standard. And as I say, as we move forward from the pandemic of COVID, this is something we know, post-COVID norm, and that's how it is. So when these things come, we've got to remember that washing of the hands is probably paramount to everything else. And of course, if you want your bacterials or antivirals, by all means do that. Eat well, sleep well, and don't be scared of going to the hospital to get checked out. And once you get checked out, comply with what is required of you. Keep the pets away. All of these are all, nothing new. They're just standard, really.
Wow. Well, Dr. Kamara, many, many thanks for your time this evening. And I want to encourage colleagues, this session has been live streamed. The link to the session is on our YouTube channel. So please, go there, share it with family and friends, because knowledge is power. But Dr. Kamara, massive thanks once again. I know you've just come back from the US, but we're so grateful for your commitment and dedication to give us real, time and intelligence on such a, live topic. So massive thanks, and hope you have some good rest.
Thank you so much.
Over to the CAHN team for the outro.
Thank you for having me.
Thanks, Doc. Ingoz's outro coming up.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.